Marija Atanaskovic Popovic. I'm an internal medicine specialist focused on rheumatology. I work at the Institute of Rheumatology in Belgrade, Serbia, and this is my institution behind me. Today, we are diving into the lungs, literally. So in the next few minutes, I will guide you through the screening, monitoring, and treatment of the systemic sclerosis-associated interstitial lung disease. Let's go! ILD is a major risk factor for morbidity and mortality in systemic sclerosis. I will briefly present a male patient with diffuse cutaneous systemic sclerosis who developed the disease at the age of 34. He presented with digital ulcers, high MRSS, ANA-ATA positivity, and high CRP. At the very beginning, he developed ILD with impaired pulmonary function tests and ILD changes on HRCT. During follow-up, he showed rapid disease progression with development of pulmonary arterial hypertension, tendon friction rub, decline in lung function, and progressive pulmonary fibrosis on HRCT. Despite multiple therapeutic modalities, the patient unfortunately died due to respiratory failure as a complication of COVID-19 pneumonia, only 3.5 years after the diagnosis. Here you can see the radiological progression over just 2 years. According to the EULAR ERS recommendations, male sex, ATA positivity, diffuse cutaneous disease, early impairment of lung function, and rapid progression on HRCT are risk factors for both development and progression of SSc-ILD. Fortunately, 3 major recently published evidence-based guideline frameworks, EULAR recommendations for systemic sclerosis treatment, EULAR ERS recommendations, and ACR guidelines for interstitial lung disease now guide and significantly support management and treatment decision-making in systemic sclerosis. EULAR ERS 2025 recommendations emphasize early and systematic screening for interstitial lung disease in systemic sclerosis. All patients with systemic sclerosis should undergo baseline screening for ILD. This includes high-resolution CT scans and pulmonary function tests performed as early as possible after diagnosis. Once baseline assessment is completed, follow-up focuses on close functional monitoring. Pulmonary function tests are recommended every 3 to 6 months, while repeat HRCT is performed every 6 to 12 months or earlier if there is clinical or functional deterioration. Finally, the management of SSc-ILD is most effective when decisions are made through a multidisciplinary approach. Rheumatologists, pulmonologists, radiologists, and other specialists review each case carefully, integrating clinical findings, imaging, and lung function tests. Equally important is involving the patient in the decision-making process. We discuss the potential benefits and risks of each treatment option, ensuring that the plan aligns with patients' preferences and lifestyle. This shared decision-making approach not only improves adherence, but also empowers patients, making them active partners in their care. In conclusion, there are 4 key principles in managing systemic sclerosis-associated interstitial lung disease. First, following the guidelines. But keep in mind that they are mainly based on evidence from randomized controlled trials. So, the second one, an individualized approach is crucial. Every patient is unique. Third, a multidisciplinary team ensures optimal decision-making. And fourth, recognizing the window of opportunity and identifying high-risk patient profiles allows timely intervention and improves outcomes. At the end, think of SSc-ILD like a fire that has already started. Early identification and intervention under water can prevent flare-ups and reduce the risk of a potentially fatal outcome.